will discuss the management of postoperative urinary retention, the diagnostic criteria, and voiding trials and success criteria of these trials. So if we define the retention, it's inability to void with full bladder after gynecologic surgery, and the incidence may range from 25 to 43% of cases. Complications that associate the urinary retention include infectious morbidity, because the patient may need recatheterization, and there is chance of UTI. The other thing is the patient may be prolonged hospitalization, which is a resource burden. There may be systemic damage, and if there is overdistension of the bladder, it may need injury to the detrus muscle. Risk factors for urine retention includes pelvic floor reconstructive surgery or hysterectomies, age more than 50, intraoperative IV administration of more than 750 ml, and recovery room bladder and urine volume more than 270 ml. And the patient manifestation, the patient will manifest mostly, they may become tachycardic, they will feel also pain, suprapubic pain, urgency to urinate, and there will be bladder overdistension that you can palpate, you can see it, palpate it, and also there will be dullness on percussion. So this you can diagnose it clinically, or you can use ultrasound, bedside ultrasound evaluation. After you identify this retention, then you have two immediate interventions. One of them is intermittent in and out catheterization. Insert, you compress the catheterization, the bladder, and remove the catheter, or insert the indwelling catheter, or you may leave it there overnight. That voiding trial, we have two types of voiding trial. We have active trial and passive trial. The active trial is structural filling, you will fill it by yourself, while passive trial is physiologic filling. So in active trial, it means the first step, you empty the bladder by using urinary catheter. You insert the urinary catheter and make the bladder empty. Then you will instill, or you will infuse the urinary bladder with normal saline or sterile water around 300 ml or maximum capacity when the patient feels the bladder is full. Then you will give the patient time, you will wait up to 3 minutes, the patient will spontaneously void or to urinate. Then you will insert catheter, and after the patient urinates, you will insert catheter and see post-voiding residual volume, which means the infused volume minus the restricted volume. While in passive trial, you remove the catheter, you encourage the patient to take oral fluids and ablate. Then you will wait maximum 4 hours until the patient feels urge to urinate, especially the first urge. After the patient urinates, you will insert catheter and you will take out the post-voiding residual volume. Then you will assess by subtracting the amount urinated or voided by the patient, subtracted from the amount that recovered from by the catheter. Then you will find how much residual volume was there. So with the method that if you use either methods, the passive or the active trial, we use this rule, 75 by 75 rule. This rule is universal. The other rule is the one is used in Parkland Hospital in the United States. The 75 with 75 rule, it means if the patient urinates more than 75 ml, or if the patient urinates more than 75%. 75 ml or 75% of the instilled urine or instilled water, the sterile water, or the bladder volume, then the patient passes, and it means the patient, you can remove the catheter. Alternatively, or the other one is used in Parkland Hospital, it means if the post-voiding residual capacity is less than 100 ml, then it's success. And the evidence of this is if post-voiding residual capacity is less than 50%, there is only 5% chance of recatheterization, while if the patient voids more than 75% of instilled volume, the failure rate will approach around 0%. The other thing is, how do we treat if there is retention, and how do we train the bladder? In normal capacity of the bladder, when the bladder volume reaches 150 to 250, there will be first urge to urinate. Then after 300 to 400, there is a strong urge to urinate. 400 to 600, there is normal maximum capacity, and more than 600 is over distension. So if there's overdistension, what happens? What's the impact? What's the clinical impact of this? The overdistension of the detrus muscle will lead the detrus muscle to become fatigue, get tired, or atonic. And consequence of that, there will be overdistension injury, and recovery of overdistension injury may take up to weeks of catheterization. High alert triggers, or the things that may indicate their possibility of bladder urine retention. It means that if there is temporary loss of pelvic nerves or urethral injury, which can happen in pelvic surgeries like vaginal surgery, prolapse repair, urethral sling surgery, radical pelvic surgery, or any type of epidural anesthesia. So how do we train the bladder? To train the bladder, we use intermittent clamp and release method. This catheter clamping, you will clamp the urinary catheter with artery for some time, then you will wait. After you clamp, you will wait 2 to 4 hours. Then you will release. It means the bladder will be filled for some time, 2 to 4 hours, then decompress it. Then again filled, then decompress it. This training will lead the detrus muscle to regain this tone and to start work movement. But the effect of this type of training is it's overload to the nurses, or sometimes they may forget the clamping and there may be another overdistension. The other method that can be used is CIC, which means clear intermittent catheterization, which means the patient will take intermittent self-catheterization every 4 to 6 hours. They will catheterize and empty their bladder. Both the two methods will lead rest of the detrus muscle and the function will be regained. So in summary, in postoperatively, we need to assess postoperative urine retention, and if you identify postoperative urine retention, you need to immediately empty the bladder. Then what you can do is you have two options, whether to immediately initiate CIC, clear intermittent catheterization, or insert catheter and leave it there, indwelling catheter. And most importantly, before you discharge the patient, you need the avoiding trial to be done and the patient should pass the test. Thank you.